Hi, good evening. I'm Josh Smith. I'm an associate member on the colorectal service in the Department of Surgery at Memorial Sloan Kettering Cancer Center in New York. And I'm a surgeon scientist who is excited about uncovering more precise treatments for each individual rectal and colon cancer patient. And I actively care for patients with rectal, colon, and anal cancer using modern surgical methods in a cutting edge and multidisciplinary setting here in New York. I'm the co-chair of the GI Oncology portfolio for the Alliance for Clinical Trials in Oncology and a member of the NCI's Rectal Anal Task Force. I serve as the chair for the JANUS rectal cancer trial and the NCI-approved phase 2 trial investigating clinical complete response and non-operative management in patients with rectal cancer trial through the Alliance for Clinical Trials in Oncology, SWOG, and NRG Oncology. I was an active investigator in the recently completed randomized trial integrating non-operative management for selected patients with rectal cancer, or the OPRA trial, and I lead an NCI-funded laboratory at MSK working to understand the molecular underpinnings of disease progression in patients with rectal cancer and try to develop individualized disease models, facilitating both effective research and more precise treatment for our patients. I look forward to discussing with you some of the findings that we learned at GI ASCO in 2023, and thank you for your time.
Okay, so some selected GI ASCO data and then some trials that I think everybody should know about. So this was the study about fucoidan, which is brown seaweed. And the primary endpoint here, this was a randomized trial to see if it improved a quality of life endpoint. Secondary endpoints were disease-free survival, overall survival, adverse events, and also changes in the gut microbiome. So as you can see here, they were able to demonstrate some differences in physical well-being as well as the colorectal cancer subscale, but no differences in some of the FACT G and C subscales that are used. But the primary endpoint was essentially the physical well-being. No differences in overall survival, disease-free survival, as you can see here in this smaller study. But this was a prospective study, small study nonetheless, that shows that the supplemental drug with the fucoidan was able to demonstrate an effect with quality of life, but no differences in oncologic outcomes, although you could probably argue that it was not powered to do so. And they did see some interesting increases in this bacteria genus, but hard to know what to make of that at this point. I think more of a hypothesis generating study at this point. So this was a study from our group looking at organ preservation in the context of total neoadjuvant therapy during the COVID pandemic as it relates to short course and long course. And we asked whether or not there was a difference between short course and long course in the context of TNT, mainly induction TNT, which is chemotherapy followed by radiation and then surgery or organ preservation. And we looked at organ preservation for the entire cohort. In maroon, there is short course TNT versus long course with organ preservation rates of 40% and 29% at 2 years. And then patients managed by watch and wait, you see 88% with organ preservation at 2 years versus 67% in the short course group. And if you look at oncologic outcomes, no differences in overall survival, disease-free survival, or distant metastasis rates, but local regrowth rates were different. You can see 36% in the short course group versus 20% in the long course group. The caveats here are this is a retrospective study. It was done during looking at our short course experience during COVID, where everybody was mandated to have short course during that period of the COVID crisis. There's no data on toxicity as of yet. And as I mentioned, there was a difference in the T organ preservation rate in those patients managed by watch and wait. The local regrowth rate was numerically different. And as I also mentioned, this is the first study that essentially looks at all patients who are getting an induction TNT approach. And the reason I bring that up is because the WashU group mainly uses a consolidation approach where they use short course RT followed by consolidation chemotherapy. They did see TME-free survival rates similar to what we saw. Our clinical complete response rates were very similar to this, which is about 47%, which is, this TME-free survival is similar to a clinical complete response rate. Their local regrowth rates are less than what I showed you. The local tumor regrowth rates are shown here between patients who had a CCR versus incomplete response. and you can see their TME-free survival data, and oncologic outcomes are similar, but there was no comparison to long course chemoradiation in this study. But just another group that has studied short course, and you should know about these data. Notes on clinical complete response, EMVI, and lymph nodes. And I'm going to use OPRA as a teaching tool for this, because this is one of the questions that came up based on the talk from Gina Brown. And just to remind people about OPRA, so this was locally advanced rectal cancers randomized to either a consolidation TNT approach or an induction TNT approach. And patients were then analyzed and assessed using a 3-tier criteria of MRI, endoscopy, and exam. If they had a beautiful clinical complete response, they could go undergo watch and wait. If they had a near complete response, they were given more time. If it evolved to a clinical complete response, of course, they could undergo watch and wait. If they had persistent tumor, they had to were recommended to go radical surgery, or if a near complete response did not evolve to a clinical complete response, they were recommended TME. And so what you see here from the OPRA data, this was presented at ASCO 2021, it is in preparation for a manuscript, that patients who have a clinical complete response have very good disease-free survival outcomes. Near complete response have an intermediate outcome. And of course, incomplete responders have the worst outcomes. And this is very similar to what has been seen in the data from the German trial in patients who go to surgery. And so we then, last year at ASCO, presented these data in patients in the OPRA trial. When you then stratify them and look at the outcomes by organ preservation according to either EMVI, T-stage, or nodal stage, you can see over here on the right, this is mesorectal fascia status. So if the mesorectal fascia is compromised, you can see they have worse outcome. This is by MRI, so this is using radiologic criteria, or EMVI, so positive EMVI, they have worse outcomes in terms of organ preservation, and then also by nodal stage. So what I'm showing here is that nodal stage does still matter, EMVI status does matter, and of course the mesorectal fascia. And these were the factors that played out in terms of negative association with organ preservation. So what are the relevant and ongoing clinical trials in rectal cancer that you should know about? Well, in terms of short course, this is the trial that will definitively answer the question about both organ preservation and then maximizing clinical complete response in the context of TNT. So this is a trial that's being run by the group in Germany. It's called 18.1. So short course followed by consolidation, FOLFOX, or long course consolidation, FOLFOX. Patients are restaged. If you have a CCR, watch and wait. No CCR, then of course you go to surgery. The endpoint is organ preservation. And you can see that this trial is accruing quite nicely. So they're more than halfway done. This was presented in November by Manos Fokas, who's the PI of the trial. And you can see, integrating watch and wait into trial is really important nowadays. And you can see that the actual recruitment is way ahead of their planned recruitment. And that's just because of I think the popularity of organ preservation. And this is no surprise to those of us who do organ preservation. So we also should just highlight the trials that are ongoing as it relates to immunotherapy. This is the trial that's run by Andres Sursik that's ongoing for rectal cancer, and it was published in New England Journal with patients having a clinical complete response after PD-1 blockade. And this is continuing to accrue patients. In addition, this is a trial led by Christian Sambor at Vanderbilt, where patients with locally advanced rectal cancer can get doublet immunotherapy followed by short course. This has been recently amended so that patients could potentially avoid radiation if they have a beautiful response, and also being amended based on the data from Dr. Sursik's trial, where patients who have a clinical complete response can be observed. And this is a 31 patient trial going across ECOG and other centers across the US, with the primary and secondary objectives seen here. But both of these trials are still enrolling, and I think important to know about. The German trial I talked to you about, and then lastly, the JANUS trial, where we're hypothesizing that chemotherapy intensification will lead to more clinical complete responses. This is based on data from the OPRA trial, and then data based on the PRODIGE trial that was published presented at ASCO 2020, and then published in the Lancet Oncology just about a year later. But we hypothesized that clinical complete response rates will be higher in those patients receiving triplet chemotherapy after long course compared to doublet chemotherapy. And the rationale here is that clinical complete response is an endpoint that's a surrogate for organ preservation. So this is the schema. Long course followed by FOLFOX and CAPOX is essentially the the comparator arm, and then the experimental arm is long course followed by triplet chemotherapy. And patients who are then restaged using digital exam, MRI, and endoscopy, clinical complete responders can undergo watch and wait. Those who have incomplete response will undergo TME, similar to what we did in OPRA. This is open and accruing, and we look forward to adding more patients on this trial as it continues to expand across centers across the US. So I'll stop there and happy to answer questions.
I have a question.
Thank you. Yeah, thank you so much, Dr. Smith. Yeah, go ahead.
So for MSI-H locally advanced rectal cancer, among our medical oncologists, there are differing views of whether or not one would be comfortable just starting with immunotherapy or immunotherapy with chemotherapy. We're just wondering what you guys are doing.
Yeah, these patients are going on trial with immunotherapy. In Andrea's trial, there's also the option to go for Dr. Simbor's trial there at Vanderbilt, where they're using doublet. I think both are reasonable options. There are some data suggesting that these MSI-H patients do have some resistance to standard chemotherapy. So I think that's something to keep in mind. And I guess you have to weigh the benefits and the risks associated with chemotherapy versus the adverse effects seen with immunotherapy. But so far we see people tolerate the immunotherapy, or at least PD-1 blockade alone, pretty well. I can't comment on the effects that Dr. Simbor is seeing with using CTLA-4 and PD-1 together, but I think that's some valuable information that we'll be able to see. I think it's been really interesting to see that they've also amended that trial to potentially avoid radiation in those patients who have a clinical complete response, which I think is important. And it's showing that, maybe immunotherapy in that subset of patients is enough, and you can just use, radiation or surgery as additional therapeutic options when you don't have a complete response.
Cool.
Dr. Saeed, do you want to comment on that? I was wondering about the niche data, like neoadjuvant immunotherapy. Do you want to say something?
So I totally agree with Josh and Nina in the MSI-H setting. The Dostarlimab trial at Memorial Sloan Kettering, or the Crescentiomor trial, both of them would be the way to go. In the MSS setting, there's really not much data out there, but if we look at the niche trial from Europe, that trial, while tailored to the MSI-H population, there were some MSS patients there, and they responded. And so I think, based on the niche trial, there is some kind of move now to bring immunotherapy in the neoadjuvant setting in the colon and colorectal space. So there is early pipeline studies being, proposed, and maybe some of them are ongoing, but early phase. So we're looking forward to that as well, because, of the fact that those patients who do not have liver metastasis, or do not have obvious micrometastatic disease, may have more immune permissive microenvironment. And so even though they are microsatellite stable, they may respond to immunotherapy better. And the best way to test it, I think, in a peri-op setting.
Mm-hmm. Mm-hmm. I think there was one question about, can radiation therapy be considered for Mets to ovaries, probably a Krokenberg tumor, if resection is not possible? Nina,
yes, so technically yes, but really, if in the clinical context, it makes sense to try to ablate all sites of disease. I think someone mentioned the Erasure trial, which is a randomized trial assessing addition of local therapy, including radiation, to, I believe, 3 or fewer, maybe 5, 3 to 5 or fewer metastatic sites in colorectal cancer. So I think technically, yes, but I think we need randomized data to see whether or not that improves overall survival.
Yeah, it's a great question.
And
then I see the question about JANUS eligibility. So the eligibility is locally advanced rectal cancer less than 12 centimeters from the anal verge. If you have a T3N0 tumor that requires a coloanal or an APR, which I would argue those are the patients most interested in organ preservation, because those are the people who need a permit or temporary or a very, facing very poor bowel function down the road. Those are the patients with the most skin in the game, shall we say. So those patients definitely are eligible, and I think would be highly motivated to enroll in JANUS. So the question is, do you think some stage 2 patients will be motivated to enroll? I'd say absolutely yes. If you're faced with an APR or a coloanal and you have a T3 and 0 tumor, yes. I saw 2 patients last week and 2 patients this week who are very interested in. I think the innate interest in saving your sphincter is extremely high, no matter what your age is and no matter where you live.
Okay, let's see. I thought that the brown seaweed question was really important, and I did Google it, and it's available on Amazon. So that was
yeah, no, you can get it anywhere. Yeah, you can get it. I think I saw it on the shelf at Walgreens.
Yeah, sorry, my answer was not very sophisticated. I honestly had not researched it, so yeah. I'm interested in learning more.
It's been around for a long time.
Yeah. Okay. Let's see if there are any questions. So we hurried through all of it. So now we have like 10 minutes time. So if you have questions, please feel free to put them in. Oh, there's a question about rectal cancer spreads through blood versus lymph nodes. Does anyone want to comment?
Yeah, I think I showed the data. We see that, EMBI and mesorectal fascia and nodal stage still makes a difference in terms of organ preservation. You see that whether you have a clinical complete response or a near complete response makes a difference in terms of disease-free survival, which is a definite surrogate for overall outcomes. We know those things do make a difference. So I think we don't have enough data yet to suggest that we can only rely on EMBI as a prognostic factor. We do know that it's shown to be a negative prognostic factor in some data sets. Is that going to be something that we can solely rely on EMBI versus nodal status? I think that's to be determined in prospective trials going forward. So I don't think we can just say, oh, okay, we're only going to rely on EMBI. Is EMBI more important than nodal status? Potentially in some patients. And I think it's something to consider when we stratify patients in trials. These are factors that will be important to stratify patients by nodal status, by EMBI. I think these are really, really important things to think about. Patients with EMBI may have a higher risk of metastatic disease, but again, some of these data come from retrospective studies, not prospective trials. I think this is where Tom's trial will be really important, where there's a lot of high quality MRI data. The Oprah study, where there was a lot of high quality MRI data. I think we need to be careful when we go back and pull MRI data from retrospective studies or clinical studies that were not prospectively done, and then all of a sudden start throwing out, okay, nodal disease doesn't matter and only EMVI matters. I think we need to be very careful about how we interpret those data.
Okay. And I was thinking that maybe for the lay audience, it might be good to explain what EMVI is. And maybe that might be one of the questions, like the spread through blood versus lymph nodes.
Yeah, so EMVI is extramural vascular invasion. So this is a tumor deposit that's a tumor that has gone into the vessels around the rectum, versus the nodes are in the mesorectum. So these are things that are read on the MRI as node positive disease, which we see at the beginning of staging. And that's how we stage rectal cancers with MRI. That's the standard way to stage it. And sometimes we do see this EMVI at the beginning of treatment, and it's important to note that, and note that this is not just some strange vein or some other artifact, but that it's truly there at the beginning, and it's in addition to a node and not a node, but in fact EMVI.
And just to emphasize the importance of getting rectal MRIs read at places that read a lot of rectal MRIs, EMBI can sometimes be subtle. It kind of just looks like a dilated vessel or kind of a dark squiggly line next to the tumor. So yeah, very important to get your rectal MRIs at places that read a lot of them.
So how do you see using ctDNA in watch and wait scenarios or in looking at current rectal cancer trials? We did have a call.
So we're collecting it in JANUS, and I think that, we're not ready to use it to make a decision. The reason for that is because if you had a false positive and you decided to take somebody for an APR, I can't put somebody's rectum back in place, right? So the stakes are extremely high. So if you had a false positive ctDNA and you took somebody for an APR, and then in fact they had a past CR, but then you find out 3 months later that in fact that was maybe a false positive for the primary tumor, but indicated that they had a disease in the lung or the liver. It's not ideal. So I think the best place to study ctDNA is in a prospective setting where we can learn where we're going to see the what the signals mean. Is it going to mean that there's disease in the primary tumor, or is it disease in the metastatic setting? And we'll see that because we're following these patients for 8 years during the course of the trial. And I think we'll collect the blood, we'll collect the data, and then we'll learn from that. So I think in Tom's trial, or in the TNT trial that Dr. Sanford covered, I think we'll learn also from that, which will be helpful. But making a decision right now about organ preservation using ctDNA, I don't think we're ready to do it yet. I wish we were there, but I think we would be remiss to do that at this point.
Okay, thank you. There's one question. It seems that the discussion on organ preservation often gets poorly simplified to an ostomy versus no ostomy, but someone at ASCO GI included the breadth of QOL impacts, which were much broader. Is there a good reference for understanding the full picture better?
Yeah, I completely agree with that. There's the LAR syndrome, low anterior resection syndrome, that is in patients who do not have an ostomy. So yeah, no, I completely agree. It's not just one or the other. I guess LAR syndrome is a good place to potentially read about that because it has a lot of the symptoms that can happen after surgery and after radiation and surgery. And there's some good literature on that, but I think we need to be better capturing quality of life, particularly long-term in watch and wait and non-watch and wait studies.
Yeah.
There are two papers, one from the Netherlands group, one from our group, looking at quality of life indices in patients. They're basically case match studies in patients who underwent radical surgery versus organ preservation. And there seem to be higher rates, the quality of life indices seem to be higher for those who undergo organ preservation. However, it'll be best to look at this in the context of a prospective trial, because, if you get chemoradiation and the organ's still in place, you might still have low anterior resection syndrome, even though the organ's in place. The question is whether or not, over time, does that wash out? And, if you have the organ in place versus if you underwent radical surgery. And I don't think we know that yet. So, I think you're correct about it's not always ostomy versus no ostomy, but at the end of the day, many people break it down to that point because they are faced with a permanent ostomy or a very low coloanal anastomosis with a temporary ileostomy, and then down the road are faced with severe LARS, which can be life-limiting.
Yeah, and then I had a question, so when you presented the MSKCC short course data and then compared with, the other paper, basically were you saying that the sequence of when you get the short course radiation seemed to affect the results? Is that?
I don't think you can compare them because it's two different. I think it's apples and oranges in some ways, because the vast majority of what we presented was in the induction setting where people got chemotherapy and then short course during the COVID pandemic. And then the WashU group, they treat in a standard fashion short course followed by consolidation chemotherapy. So I think it's a little bit of a different cohort. At the end of the day, we still saw a difference in local regrowth. So I think that's notable. The clinical complete response rates actually, interestingly, are quite similar between the two groups. I think trying to compare them in a direct fashion would be incorrect. That's why I point to the German trial. I think the German trial will be a paradigm-changing trial as it relates to which one do we think will provide more clinical complete response and organ preservation. And the hypothesis there is that at least the way that Dr. Focus has done it, is he hypothesizes that long course will lead to higher rates of clinical complete response. We'll see if he's right.
So for a patient like who has to make this decision and is favoring short course, do you think that getting the radiation first may be better if they want organ preservation?
Yeah, I think based on the Oprah study, looking at sequencing in organ preservation, either radiation or chemotherapy first, we think that doing radiation first and the longer wait from radiation to assessment gives a higher rate of response.
Yep, I would agree with that. I see Annie's question. JANUS is now open across more than 60, I think now maybe even 70 sites across the US. So not just MSKCC and University of Florida. It's all it'll be open across the NCTN.
Okay. What was the other question? This is for Dr. Saeed. If people want to get on a vaccine trial, what are some of the things to keep in mind?
It really depends on the type of the vaccine, because there's multiple vaccine types. There are like neoantigen vaccines, there are virus-related, vaccines, and the making of those vaccines, logistics also, need to keep that in consideration, because some of them are tumor tailored to like certain tumor antigens, and patients have to be pre-selected to go on those studies. So typically not relevant to colorectal cancer, but even in other disease types, typically those studies are combined with IO and later line setting. There's actually an ongoing trial in the frontline space combining, in a maintenance space, combining neoantigen vaccine with PD-1 inhibitor and chemo after dropping oxaliplatin. So there's an ongoing maintenance setting colorectal cancer stage 4. But it's a neoantigen vaccine. It requires pre-selection as well. So, so one thing to keep in mind from patient standpoint is like when they are going to be treated, when they are treatment naive, is to ask about studies, because getting that sample to be checked and pre-screened is very important to be able to get on the study in time.
Okay. And then there are some, nowadays there are vaccine trials for ctDNA positive population, right? After initial therapy.
Yes,
so do you want to
Yep. And those studies also requires pre-selection based on ctDNA. And so, for example, in this scenario, if the patients are not tested for ctDNA in the right window, then they loses the ability to go on the study. And so it's always important to ask about those studies. If the patient is in a center where he's getting, surgical and medical oncology consultation, in the community, it's always good to ask, is there a peri-op study? And if there's a vaccine study, can we talk about this? That helps. Because, we get the referrals after chemotherapy, and then even if we check the ctDNA, if we lose that window of ctDNA testing, then it's hard to enroll.
One thing that was a little unclear to me about that the first paper I think you covered was when people talk about active liver mets, and I asked this question to them there, but I don't think I got a good clear answer. What is the difference between an active liver met and, I mean, to me, they're all, I don't know. How do we define this? It doesn't seem clear to me.
I don't think there is non-active liver mets unless they are treated. So if someone has, for example, SCRT or any radiation or ablative approaches, then it's non-active. But I think the oncologists in the community are used to using active when they see things, as if we are, interpreting a PET scan and, if DG have it's, lesions versus not. But, if there is a liver mets in the setting of colorectal cancer and they're untouched, then they're active.
Yeah. Okay. I think it's a little bit strange, the way that was, anyway.
Yeah, and then I think this question, maybe I think our last talk covered it, like, is it always ideal to remove the primary tumor even if it has responded well to FOLFOX and is now just seen as a thickening of the bowel wall? Anybody can take it.
I think there was a recent study that showed removing the primary tumor did not really impact.
Yeah, it's controversial. I didn't cover this talk because I think it's still fairly controversial. It depends on which year you look at. So the Japanese presented data last year at ASCO GI. There was a Chinese study this year suggesting that maybe there was some role of removing the primary, but I think the bulk of the data to date does not suggest the role of removing an asymptomatic primary tumor. If you're the primary tumor with either bleeding or a symptomatic primary tumor, it's different. But an asymptomatic primary tumor, the removal of that, I think, for now, we don't have data to support that. At least based on some of the randomized data prior to what was presented at ASCO GI. I didn't present that paper because I think it's still a little controversial.
Okay. So we have 1 minute maybe. I'll ask each of you, what is your main takeaway from ASCO GI? Is there something, just one thing that you want patients to remember? Maybe Dr. Said, you go first.
I would say always ask for trials, because there's always ongoing studies, and it's hard to find patients when it's always good to be proactive from patient standpoints. There's a lot of studies, and those studies will add to the field, and they may change, standard of care. And it's always good to, to take that opportunity.
Okay, thank you. Dr. Sanford?
I would say maybe something radiation specific is that radiation is really not one size fits all, or even just between short and long course. There are different ways to sequence it, different ways to deliver it. And I'm excited that future studies are going to be kind of figuring out how to optimize radiation for different patients.
Okay, thank you. Dr. Smith, what is your take?
Not every GI ASCO has a practice-changing abstract, which is fine. So take everything with a grain of salt, digest the data carefully, and put it into context.
Okay. Thank you very much. This was very, very, very informative, and thank you for your time, and thanks to everyone for attending.
Thank you.
Thank you.
Thanks so much.
Yeah. Bye.
Bye-bye.
Bye.